Okay, so good evening, everybody, and welcome back to Fertility Week. This webinar is the fourth out of a series of 5, and it's going to be on recurrent miscarriage. So Fertility New Zealand is a registered charity, and it's been operating for 20 years. We're here to help people through their fertility journeys. We do this by information, the 100 number, and a support. We also provide support, and we do this by a number of support groups that are throughout the country, and we also provide advocacy. So tonight's webinar is going to be presented by Dr. Karen Buckingham from Repromed here in Auckland, and she specialises in recurrent miscarriage. The format's going to be the talk, and then we're going to do questions at the end, and we'll do that by, you can just pop them into that chat box down here in the corner, and yeah, so, and hope you enjoy the talk, and I'll let Karen take it away. Thank you.
Right, thanks very much. And welcome everybody to tonight's talk on recurrent pregnancy loss. As Jenny said, I'm a specialist in reproductive medicine, and I have a special interest in recurrent pregnancy loss. And although I don't run it anymore, I used to be in charge of the recurrent pregnancy loss clinic at the Green Lane Clinical Centre. So how I thought I'd approach this talk would be to tell you a bit about what recurrent pregnancy loss is, and also maybe some of the risk factors that can contribute to it, as well as talk about some of the causes and how we might investigate a couple who are experiencing recurrent pregnancy loss. Talk a little bit about treatment and the management of it, and then I've also got some slides at the end that have been put together by our counsellor to try and help people cope with the emotional impact of recurrent pregnancy loss. So feel free to ask any questions as we go through, and I'll try and answer them either during the talk or essentially at the end. So firstly, recurrent pregnancy loss or miscarriage. We know miscarriage is really common. You know, it affects at least 15 to 20% of all pregnancies, so it's a really common phenomenon. But it's less common to experience miscarriage after miscarriage after miscarriage. And so, although there's different definitions, recurrent pregnancy loss classically refers to the occurrence of 3 or more consecutive miscarriages or losses prior to the 20th week of pregnancy. That's sort of the standard definition we use in this country. And the number of people, the percentage of population that affects is probably about 1%, so it's still not uncommon. Okay. There are some risk factors for recurrent pregnancy loss, and it'll be no surprise to hear that the biggest risk factor for it is advancing maternal age. And this graph's a really good reminder that as a woman ages, her fertility, that's the blue line, declines quite markedly. But if you look at the red line, that's showing you that as a woman ages, her risk of miscarriage increases almost exponentially. So I know this graph's a little bit small, but if you can see down at the bottom, when a woman's over 45, she has an almost 93% chance of that pregnancy ending in a miscarriage. And I guess it's no surprise that, you know, as we leave it later in life to start our families, we're much more likely to have miscarriages. And I particularly like this quote that Sarah Vallis wrote in his paper in 2012, that women in their 40s are 100 times more likely to suffer recurrent pregnancy loss due to chance alone compared to women in their 20s. And I think we need to bear that in mind when we're thinking about investigating women. However, it's not just, I was also going to say, the reason for miscarriage increasing as a woman gets older is that, unlike men who make sperm all the time, we're born with all the eggs we're ever going to have. And so if an egg's been sitting in our body for 40 years, it doesn't divide or work quite so properly as it could have done when it was, you know, only 20 years old. So it's because our eggs are older that miscarriage is much more likely to happen. It's not just the woman's age though. Paternal age makes an impact as well, although probably not as marked as for women. But we know that if a man is over the age of 45, he's much more likely to suffer a miscarriage with his partner and take longer to impregnate that partner. So again, if you have that combination of an older man and an older woman, you're going to be much more likely to be at risk of miscarriage or recurrent pregnancy losses. Another risk factor for recurrent pregnancy loss can be someone's previous reproductive history. So if someone's had a live birth in the past, I'd be much more optimistic about that couple having a further live birth. Conversely, if they've always had miscarriages or pregnancy losses, then I'm a little less optimistic about them. And as you can see, and this is quite an old study, but the risk of miscarriage increases with every successive pregnancy loss. Having said that, after 3 miscarriages, your risk of another miscarriage is about 33%, so you've still got probably at least a 70% chance of an ongoing live birth subsequently. It does depend a little bit on what the cause of your pregnancy loss is, and I've just put this example here of a genetic cause of a translocation. A translocation is where the chromosomes are the normal number of chromosomes, but they're rearranged in different ways. And there's various types, but depending on where your what chromosomes your translocation affects may give you a different risk of having a miscarriage. So for example, if you have a 22-22 translocation, you're almost always going to miscarry, whereas if your translocation affects chromosomes 13 and 14, your risk of miscarriage subsequently might be 25%. So some different causes will give you a different risk of another miscarriage. Now, there's lots and lots of causes that have been postulated for recurrent pregnancy loss, and I've made this table up so you can see when we're thinking about a couple with recurrent pregnancy loss, there's a number of things we tend to consider. We think about, could there be a genetic cause? So is there something about that couple that makes them more likely to have an abnormal embryo? And so that's in that genetic box. Or we think about the woman's uterus. Is there an anatomical abnormality that makes her more likely to miscarry? So does she have a septum in her uterus, or does she have fibroids that impinge in the cavity of the uterus, or does she have polyps there or adhesions that might stop an embryo implanting quite so well? Someone who's having second trimester miscarriages or later miscarriages, sometimes the cervix can be incompetent, so it doesn't hold a pregnancy quite so well, and those women can miscarry in the second or third trimester. It's the whole group of possible theories about maybe there's an immune cause for women's miscarriages. The only proven immunological cause is something called the antiphospholipid syndrome, which affects maybe 10% of couples who come along to the RPL clinic. And that's a condition that's associated with other pregnancy complications, such as preeclampsia, or it's also can be associated with thromboembolic events, so people might have had clots in their legs or their lungs. So like I say, that's one of the things we definitely test for to make sure they don't fall into that, have that syndrome, because if they did, there's a specific treatment we would use for those couples. I've put here question marks beside the other theories in there, because although they're postulated, we don't actually have good evidence that they are a true cause of recurrent pregnancy loss yet, although a lot of area of interest is in this area. I've put this box down here called thrombophilias. Now, thrombophilias are an inherited group of disorders that cause people to have a greater tendency to form blood clots, so DVTs or pulmonary emboli. And it's wondered whether some of those thrombophilias can be associated with recurrent pregnancy loss. And I say wondered because there's a really large and contradictory literature looking at them. There's many different types of thrombophilia, and we think that some of those are more likely to be associated with miscarriage than others. So I've just listed a few here. Again, there's a whole box of, are there any hormonal or endocrinological causes? So we know if someone's got really uncontrolled diabetes or very poorly controlled thyroid disease, they're often more likely to miscarry. It's questioned whether polycystic ovarian syndrome women have a greater propensity to miscarriage, and sometimes women who have got high prolactin levels may be more likely to miscarry. There's also this possible condition called luteal phase defect, where the luteal phase of someone's cycle is deficient and it causes the pregnancy not to progress. But again, these are all a bit not quite proven. There's no, we're not actually sure if those conditions actually are associated. There's quite a bit of work now on lifestyle factors. So as we mentioned before, if someone's older when they're trying to get pregnant, they're more at risk of miscarriage. If someone's BMI is outside the normal range, so if they're very underweight or they're very overweight, their risk of miscarriage is increased. If someone smokes cigarettes, their risk is also increased, and it's a dose-related response. So the more they smoke, the greater their risk of miscarriage. Equally, with caffeine and alcohol, we think there's also that that exposure can also increase your risk of miscarriage. And it's postulated about other environmental exposures, such as, radiation from VDU screens or anesthetic gases, all those sorts of things. We don't, again, have great evidence for them, but it's been thought about. So those are a number of causes, but in fact, the actual greatest the greatest thing we find when we investigate these couples is that it's unexplained. We just can't find a reason for why they're having those recurrent pregnancy loss. So at least 50% of couples will fall into that unexplained category. And it probably explains that we don't actually know everything that's going on at that very tiny microscopic interface between the embryo and the uterus. So how do we investigate someone who's experienced recurrent pregnancy loss? Well, I've listed here on the list of tests that I would consider we would do that pretty routinely for most couples. So we'd want to check both the parents' karyotypes to make sure they didn't have a translocation, an additional chromosome or anything like that. We'd want to do some sort of assessment of the uterus. So that might be doing a three-dimensional ultrasound scan, or it might be doing a hysterosalpingogram where some dye is put up inside the uterus, comes out the tubes, and make sure there's no abnormalities inside the uterus, or it might be a hysteroscopy. Those are the sort of main investigations we would do for that. As I said, we test for antiphospholipid syndrome. Now that involves a blood test, and it's looking for some certain antiphospholipid antibodies. And the names of those are the lupus anticoagulant, anticardiolipin antibody, and beta-2 glycoprotein 1. Now, if someone is positive for an antibody, it's not enough just to be positive once. You have to have significant levels of them at an interval of 12 weeks, so on 2 occasions, 12 weeks apart. So again, you might have a blood test, and if it was positive, we'd ask you to repeat that in 12 weeks. And if it was again positive, then we'd be more thinking that you had the antiphospholipid syndrome. We test for your thyroid function test, and possibly for thyroid antibodies. And I've just tested here, we test someone's ovarian reserve. So that's sort of a count of how many eggs they may have in their ovary. So that would usually be an anti-Müllerian hormone test, or a day 2 FSH test, or an antral follicle count. And sometimes there may be additional tests depending on what the history's told us. So if the patient's got a history of lots of clots in their legs or in their lungs, we might be doing a full thrombophilia screen. Or if someone's got milky discharge from their breasts and headaches or visual problems, we might be thinking more seriously about checking for a prolactinoma with a blood test and a scan. Now I've listed on the right-hand side a whole lot of other tests that are not routine but are used by some practitioners. And so that's things like checking for natural killer cells and endometrial biopsies and rarer sort of thrombophilias. So again, you might see that or have been asked to have those tested, but like I say, they're not particularly routine, or certainly not in the clinics that I've worked in. So how do we manage recurrent pregnancy loss? Well, it's a really frustrating area to work in. And I guess that's just because the cause, we often find no obvious cause for why people are miscarrying, and there's very few evidence-based treatments. The choice of treatment really depends on whether we've found any underlying cause of the recurrent pregnancy loss. So I'll talk a little bit now about what some of the treatments might be if you had a particular cause for your miscarriages. So if you had a genetic abnormality, so say you had a translocation, which are not uncommon, then your choices, depending on your particular translocation, we'd always send you off to the geneticist, who would be able to give you a greater, more specific risk for your particular genetic problem. But it might be things like doing something called pre-implantation genetic diagnosis. So that's where we do an IVF cycle and the embryos are created, and we then biopsy those embryos and test them to make sure that the embryo doesn't have that translocation, so that we can hopefully then only put back a normal or unaffected embryo. And we think of doing that, then we're going to give you a better chance of pregnancy. That's a very simplified view of PGD. Or it might be that if we think you've got such a high chance of having an abnormal embryo using the partner's sperm or eggs that are affected, it might be that we say maybe you need to think about using donor sperm or donor eggs to overcome. Or in some cases we might just say, look, you still have a chance of having a normal ongoing pregnancy, but you may be at risk of more miscarriages. So if you keep trying, even if you have another few miscarriages, you may still be lucky enough to have an ongoing pregnancy and live birth. As I said before, we get quite excited when we diagnose the antiphospholipid syndrome, and that's because we actually have a proven treatment that's of benefit. And so what we do for those couples is that we treat them with anticoagulation therapy. So we usually give them heparin throughout the pregnancy, and that's been shown to certainly improve the live birth rate significantly. So like I say, we really like making that diagnosis because we can say, here's a treatment for you. But that only probably maybe 10% if anything of the couples that we see fall into that category, unfortunately. Again, if there's an anatomical abnormality and it's correctable surgically, we will try and correct it. So if someone's got adhesions inside the uterus, or they've got a polyp or an intrauterine fibroid impinging on the cavity, we'd try and surgically remove that, because by normalising the cavity, we'd be hopeful that they'll be able to then have an ongoing pregnancy. And that applies also for if someone's got a uterine septum, we'd try and resect that. Now, sometimes it's not possible to correct them. Some people have had multiple surgeries trying to remove septums or fibroids, and it's just far too difficult, or it can't be done, or it causes more problems with scarring and things. And so in those cases, it may be that you need to have a surrogate, which is where another woman carries the pregnancy for you. So again, that's a pretty big step, and certainly wouldn't be our first choice of treatment, but in some cases that seems to be a treatment option for some women. If someone's got an incompetent cervix, where the cervix opens before the pregnancy is ready to, fully developed, it's possible to put a stitch around that cervix to keep that closed until the child's of a sufficient age to be born. So again, that's a specific treatment for a specific problem. So if someone has unexplained recurrent pregnancy loss, then people have tried all sorts of treatments to try and improve the outcomes. They've given them things like heparin and aspirin and beta-HCG and all sorts of hormone treatments, and none of those have been proven to work. There's been really good studies, so we know that giving Clexane and aspirin to women with recurrent pregnancy loss does not work. So we certainly don't offer that. But we do know that it seems to be that if you offer women in that situation support in a designated clinic, then that can be really helpful. And so I've just said here, and just over half of couples, we don't find any obvious cause. And so for them, we're really trying to optimize their lifestyle factors as much as possible. And so definitely stopping smoking or using any recreational drugs, reducing alcohol and caffeine. People are often really concerned they're going to have to give up every bit of coffee, but actually it seems to be if you drink more than 2 cups of coffee or the caffeine equivalent of that, that's when your miscarriage risk starts to increase. So you can still have a cup of coffee every so often, but just not more than 2 cups a day. Again, being a healthy weight and in the healthy BMI weight range would be really helpful as well. And so by making attention to those lifestyle factors, we know that your chance of a subsequent pregnancy is at least 70 to 75%. So even though you've had 3 miscarriages, your chance of an ongoing pregnancy next time is still really high. So it's really important to keep that in mind and keep trying. Like I say, when someone comes to our pregnancy loss clinic, we offer them sort of supportive care and early pregnancy monitoring. And I think when you've had lots of miscarriages, it's really nice to be able to be seen by a clinic that understands a bit what you're going through, and also knows how to manage you a bit more appropriately. So like I say, we monitor you by doing quite frequent beta-HCG blood tests if you want that, and then we start scanning you from about 6 weeks, and usually do that weekly so that we can see that the baby's growing appropriately. Now, some people don't necessarily want that degree of intervention or monitoring, and that's fine. It's a very individual choice, but if someone would like that, then that is available to them. And you might ask, well, monitoring is not going to stop me from miscarrying. And you're right, it's not. But at least if we're monitoring you, we can give you a much earlier indication if this pregnancy is likely to be ongoing or if it's likely to be miscarrying. There's nothing worse than getting to 12 weeks thinking the pregnancy is going along beautifully and then finding out that actually, baby died at 6 weeks and, all your symptoms have disappeared, sort of thing. So at least I feel it's better this way if you find out actually at 5 weeks things weren't looking so great, the pregnancy hormone levels weren't rising appropriately, and so you can sort of prepare yourself a little bit more for what the outcome might be. So I'm just going to go to the next one. Yeah, so the next few slides have just been put in by our counsellors, saying that couples who are experiencing recurrent pregnancy loss require a lot of empathy and understanding. It's a real loss of hopes and dreams. As soon as you're pregnant, you have planned that child's life out. You sort of mapped it out. Exactly when you're going to be giving birth and all the rest of it. And so when you miscarry, it's a really real loss, but often one that's not necessarily recognised by friends or family members because it's not something they can actually see. And remember that the experience of miscarriage is unique. So women will have very different physical, emotional, or spiritual experiences, and no one way is the right sort of experience. And all these feelings of sadness and disappointment, devastation, all those are all very real, and there's nothing to be ashamed of for feeling those. And I guess the frustration or the difficulty can sometimes come in when you and your partner may have different ways of experiencing it or having different feelings, and that can sort of, you know, separate you a little bit at that time. So I guess it's being aware that your partner may experience different feelings and may express themselves differently as well. So it's really important to, you know, give yourself permission and give yourself time to grieve. You know, don't expect to just be over it next month. You know, there's no set time period. Just because your friend, you know, bounced back in a month doesn't mean that you necessarily will do that. So you shouldn't sort of put expectations around when you should feel better. It's often a common response to want to get pregnant straight away and be pregnant again, and that's fine, and there's no physical harm in doing that. But I guess you also need to be prepared, you know, for if it is a miscarriage again, are you going to be resilient enough to be able to deal with that again at that time? And so sometimes it's quite nice to be able to sort of acknowledge your loss in, you know, the ceremony or a symbol or writing a letter or taking a photograph, you know, something to sort of symbolize that loss so you can remember it in a more sort of positive way. And it's a good idea to, you know, tell people if you want their support or if you don't want their support. You know, people are wanting to help, but it's very hard sometimes to know exactly what help will be useful to you. Our counsellors are always available if people wish to talk to them, so it's always, you know, feel free to make contact with them or with other people, especially with Fertility NZ. They've got great resource groups and contact groups there to help. And sometimes if you do have a plan, like it's good sometimes to come along and have a chat to your doctor about what they think your chances are and maybe what your goals could be going forward, and if there are any particular treatments you should try, or whether, you know, you should just continue doing everything you've been doing at once. And remember, take time for yourself to rest and recover and, you know, get into routines and things, because that gives you some sort of control as well.